It's first time, I think so, where almost all the wards, every possible wards were filled up. So, so all these days we had patients, but there was a epidemic. Do you agree with this term, epidemic? Okay, so there was an epidemic of this rickettsial fever and also dengue-like fever and all. So what antibiotics the doctors tried, most of them were not that much helpful for these patients. So the fever was very high and most of them took all the possible antibiotics also, even though we knew that this dengue fever is a viral infection. Though we knew that it's a viral infection, we used to treat these patients who used to come with some antibiotics. At least if we are given some paracetamol, they would tell us that I have already taken these medications. This is the same dialogue which we heard recurrently, and patient was not happy if you have not given the drugs which are costing high. So the patient started changing one doctor to another doctor, from basic BMS doctor or the consultants from the basic village where they were placed, and they came to the higher center in Davangere and they got the best medications, but still the fever was not that much reducing. Okay, so the disease took at least 10 days, 7 to 10 days. It's the normal course where the dengue fever will subside. Okay, so this topic, this situation was relevant because we use the antibiotics maybe irrationally, or there was a rational use in order to save the patient, or we can tell that even though we knew that this antibiotic may not work, but still we may have to give this to the patient to decrease the fever. Okay, so I have used the term rational use and irrational use. Okay, so we'll be learning more about this rational and irrational part of it. Okay, so coming to the first slide here, I have put a slide where the doctor is trying to kill the bacteria with a syringe. Okay, so is it so? Yes. So if you carefully observe, there is one more needle at the bottom. Okay. So one more needle at the bottom, that means this is a second needle which he has put. And if we can observe a little more, there are other broken tablets also, at least 3 or more tablets. That means patient might have taken, or the medical person or a non-medical pharmacist, he might have given the tablets, then he might have tried one more drug. That means this is the 5th injection or the 5th drug which the patient is already on. Okay, still we don't know what will happen to this bacteria, whether it will be killed or not. So antibiotic resistance is a major problem which we will be facing, and this is a global emergency. Why this is a global emergency? Because all the top organizations who are associated with the health, you can start with World Health Organization or Center for Disease Control, CDC, or Infectious Disease Society and CDC. These are the prime organizations which will be time to time which will be updating us based on various diseases and what are the vaccines we should take and all. So all these organizations are giving us hints that we are crossing the margin. So what margins or what path we should adopt and why we should take care. Okay, so coming to the basic understanding of the term antibiotic resistance, there is peaceful coexistence. Okay, so I'll use the term, there is peaceful coexistence of the drug also and also the bacteria. That means they have become friends. Okay, so why they become friends? Because the dose which we are using may not be appropriate, or the course which was told by the doctor might not be taken correctly. So do you remember when you have last completed the antibiotic course? So doctor might have given it for 5 days, 10 days. We rarely complete. We doctors ourselves are bad patients. Do you agree with me? Okay, so why we have bad patients? Because most of the time we may take incomplete treatment and think about the patients who might not be affordable to those drugs. That is the bad situation. Okay, so this is the antibiotic resistance develops when bacteria adapt and grow in presence of the antibiotics. So I have placed the culture medias. So you might be familiar with these microbiological plates. Okay, so the first plate, what we are seeing here, is showing that there is a blood culture there, and literally you can think for understanding that those white dots are the tablets which we are taking. Okay, so if we are taking those tablets, and here we see this may be the situation in 1960s or 70s, where almost all the bacteria died in presence of those tablets. But today's situation, this is not the today's situation. Actually, you can take it as around 10 years back. Okay, maybe in 2005 or 6. Okay, so most of the tablets are not effective. That means the blood culture has completely grown. Okay, like this we have to be. Our bacteria are growing stronger day by day. Why and how we'll be learning. So the need of the hour, why we need to save these antibiotics, that is very important, because our government is now telling more and more about the renewable resources and non-renewable resources. Okay, so these resources are non-renewable. Okay, so once consumed, the antibiotics is will no longer be usable for the other persons. That means the plant which they have kept, okay, not only the consumable part, the plant or the industry which they have kept, they produce the antibiotics which are non-renewable. Okay, so once it has the resistance has developed, it will be rapidly communicated. Okay, so how does the rapid communication spread? Suppose a very good movie is there in the theater. Okay, it's like that. Okay, so how it is transferred across WhatsApp groups, like this movie is good or this movie is bad, like that. Okay, so and there is some watermark between the gram positive and gram negative organisms that I'll be showing in the slides. So infections resistant with organisms, they will increase mortality and morbidity. Suppose we think the oral pathology department may be having five members as a staff and who will be engaging you the classes. So if the doctor is ill, so last week our principal was also ill. Okay, so because of these fever, and if only 3 persons are available, your classes will be disturbed. The same you will be holding good if the earning member of the family is ill. Okay, so the mortality and the morbidity associated with the disease will go on increasing if there are resistant strains. Okay, so reduce treatment options. So suppose the person is not taking the drugs regularly. So this antibiotic resistance, the concept is very much relevant to the disease that is tuberculosis. Have you heard of tuberculosis, everyone? Yes? Okay. So I am seeing blank faces because most of you have decided that this will be a boring class from 3 to 5. Okay, I am not seeing the smiling faces or responding faces there. Okay, so I will not be boring you. I will be trying to grab some of the ideas from your side also. Okay, so tuberculosis, the disease lord or disease king you can take, because in everything in India there was a statement which was told, there is a fever, any patient in India, you try to diagnose. If it is not there, if you are not able to diagnose anything, think of tuberculosis. Okay, so tuberculosis is, you can present you any form in India. Okay, so starting with skin tuberculosis or the lung tuberculosis or any other pattern or abdominal tuberculosis. Okay, so this tuberculosis has now become multi-drug resistant, and it is now also a totally drug resistant. Strains have also developed, what they call it as XDR. So untreatable infections. So you might be knowing about the viral infections which are untreatable. Okay, so they were untreatable previously. They are not untreatable. They are less treatable now. They may be treatable in the future, but still we try to treat some of the viral infections. So you might be knowing the recent data produced by US. They tell that more than 10 years lifespan of the HIV affected person. So almost it is considered that very good outcome with the treatment. So increased healthcare cost. So in India, very less people are having health insurance. Why this is important? Because most of the time our patients are not affordable to the treatment, and we do not have a system of the government taking up the insurance, or the government taking up the treatment of the subjects. Okay, so but abroad they have the concept of health insurance. That's why most of the time they are affordable, partially affordable, not so much as the well-versed. But here in India it is very difficult. Most of the cancer treatment or the antiviral treatment, there will be less than 10% of population who will be affordable to it. So I'll be just telling about what are the resistant species presently we are having. Okay. So pneumonia, have you heard of pneumonia? Okay, so it causes lung infection, as simple as it. Okay, so this species now they are resistant to penicillin and penicillin associated groups. So penicillins, they can be called as beta-lactam antibiotics, or short form they tell it as BLs. Okay, so these beta-lactam antibiotics are now having the congeners, that is cephalosporins. Okay, beta-lactams or the penicillins or the cephalosporins. I have seen most of the dental doctors, they use amoxicillin, right? They use amoxicillin plus metronidazole or tinidazole. Yes, these are the only two antibiotics. Because I heard one of the pharmacists next to the dental hospital telling, this doctor only prescribes these two drugs. I don't have business from this doctor. Okay, so most of the time these most of the dental specialties, they try to use this amoxicillin and metronidazole. Okay, so amoxicillin is a congener of penicillin. Okay, it's a orally available penicillin congener. Okay, so that has got resistance now. So HIV, so this anti-HIV drugs, there is lot of variation because HIV itself is a retrovirus. Okay, so it's a very complicated and master virus. So we need not speak much about it. So the agent causing dysentery, 90% resistant to cotrimoxazole. So you might be knowing about the prophylaxis which we give presently for the HIV affected people who come for dental extraction, or for the local, they come for this GE, okay, gastroenteritis. They give prophylaxis of cotrimoxazole. Okay, this is the government prescribed prophylactic drug for HIV affected people. Previously, this cotrimoxazole was a basic drug, Septran. Have you heard this drug, Septran? So when we were kids, about 20 years back, the popular pediatrician here in Davangere, they always used to give Septran. Okay, one sheet, 10 rupees, 1 rupee per tablet, the disease is cured, 3 days. Okay, so that was the condition, but now they have come back again. It's not that it was used previously, now also it is used. It has regained its importance because of the antibiotic resistance, and it is also a cheaper mode of drug, and there is a resistance now for it. So tuberculosis, so this tuberculosis, you might have heard that this regimen is for some 6 months. Am I right? Yes. Okay. So this tuberculosis regimen is for 6 months, and we use a set of how many drugs? 4 drugs, and followed by 2 drugs. So this among these 4 drugs, if it develops resistance to the popular 2 drugs, if you can remember the drugs, HRZS. Okay. So if it resistance develop to this INH and rifampicin, okay, we call it as multi-drug resistant tuberculosis. So coming to the malaria. Okay, so malaria is more rampant among the regions where there is more use of coconuts. Okay, so you might have heard about Tumkur. Yes, anyone from Tumkur here? No, because Tumkur, Tiptur, these are the belts where more coconuts plantations are there, and where the open half-cut coconut will be there, which is a very good breeding place for this malarial parasites and the mosquitoes. Okay, and Sir Ronald Ross has identified it in Chicknack-Nully near Tiptur. Okay, so this is the regions which are endemic to these diseases, and we have found out those things. And chloroquine is the first drug which is used. It's a synthetic drug actually. Quinine bark was used previously, but the synthetic one is chloroquine, and chloroquine based treatment is now no longer commonly used. Now we are using the artemisinin based derivatives. So sorry for the slide, but this is a slide from the WHO, okay, World Health Organization, and here I am trying to show the comparative chart which World Health Organization has put. Excuse me. So this World Health Organization has put the comparative chart for tuberculosis, malaria and HIV infections, where we need to take care what are the questionnaires. Okay, so here the first point here is appropriate use of antibiotics should be there, detection of pathogen can we make it, and are we observing the treatment? That is the important part. So if you can remember the treatment of tuberculosis, which is for 6 months from government hospital, we call it as DOTS regimen. Okay, direct observed treatment for short course, like that. So this is the observed treatment, but till now we do not have that for the HIV, malaria and other bacterial infections. So why I am stressing this is because if we try to adopt that method for other things, we can ensure that the patient or the person who is affected will take this antibiotics appropriately. Once the appropriate treatment is there, that means the sufficient amount of drug is there in the plasma of the person, there is less chances of antibiotic resistance. Okay, that is the only thing we need to understand. Okay, so HIV infection, nosocomial affection will be there. Okay, and here there are less chances. The drug interaction with HIV drugs is very important, because once the immunity of the person is affected, then the patient is vulnerable to basic infections. It may be the bacterial infection starting with gastroenteritis or the malaria or so. So here we discussed some of the bacteria and their resistances. Okay, typhoid, Salmonella typhi is showing multiple resistances, and this we discussed. Okay, so nosocomial infections, there is one term. Have you heard about this, nosocomial infections? So that means you have used a dental instrument or any instrument from the patient who was already affected, and you have reused it, maybe with the sterilization or without the sterilization. It is possible that you can transmit the disease to the person who has come to you. That means within the hospital we can make the patient acquire this disease, or it may be the person who has come to the inpatient to see the inpatient, and he got bite or he gets affected by the cough droplets of the admitted person. Okay, so the basically infection acquired in the hospitals. Okay, so nosocomial infections, and these are very dangerous. Why these are dangerous? Because methicillin and vancomycin, these are the tertiary level drugs. That means already you have used the basic drugs which you have discussed, penicillins, cephalosporins or cotrimoxazole, and the latest one drug is vancomycin, and these agents or these bacteria are resistant to vancomycin. So what shall the doctor do now? So we are literally left with no options. Okay, so suppose such system evolves and most of the patients develop this type of vancomycin resistant or methicillin resistant species, will be the world without drugs. So can you imagine world without drugs? Is it possible? Can you go back to that era?
It is possible.
Possible?
Possible with maybe integrated medicine, bringing the concept of integrated medicine.
Yes, sir. So there is a concept of integrated medicines, but actually when we tell integrated medicine also, they are also using some drugs, but actually they are not given the name drug to it. So if you can remember the first statement of Patanjali in Ayurveda, what he tells is no drug is poisonous, or every drug is poisonous when it is not used in its appropriate dosage. That means everything what we use for curing any disease can be called a drug. With that concept, we cannot imagine a world without antibiotics also. So trends in antibiotic resistance. So this is from 2004 till 2008. Okay, so these are the in decreasing order. What I have put is the we go down the table, these are the higher antibiotics. The first thing I have put is cephalosporins. Cephalosporins are higher antibiotics. Then aminoglycosides, fluoroquinolones, that means the ciprofloxacin, ofloxacin, then BNs, that is the penicillins, okay, beta lactams are the penicillin groups, then the carbapenems and polypeptides, these are higher antibiotics. If you look at this red line, what we are taking, that is aminoglycoside, that is streptomycin, which is a drug for our tuberculosis, okay, injectable antitubercular drug. So around 80% it has fallen down just below around 12%, okay, the susceptibility has very much decreased. That means we need to find a new drug to treat tuberculosis. Tuberculosis is very rampant now also. If you can carefully observe the people, among 100 patients, you will get 2 to 3 patients. They tell it is near eradication and all, but the practical situation is different. Okay, they tell this eradication principle as no detectable case in 10,000 population. So if we take that criteria and we are not screening the patients clearly, it will be difficult. So antibiotic resistance, how it gets, okay, so here is a resistant species of plasmid. Okay, so to understand the concept of plasmid and E. coli, if you can remember the insulin, okay, so and everyone knows about insulin, has heard about insulin. Okay, so how do we produce insulin? We introduce actually the insulin containing 51 amino acid gene into the animals, or we get it from the animals, and now this recombinant DNA technology, what we are doing with the help of E. coli, we are giving that sequence and we are extracting it. So these bacteria have become so smart that they are transmitting this through plasmids. Okay, so that means they can transmit across their friends, okay, irrespective of the different group or different species, but the watershed is maintained between the gram positive and gram negative. So mechanism of resistance, one thing I told is plasmid mediated, that is very dangerous. Other mechanisms are there, okay, efflux mechanism, that is just before entering the hall they throw them out, okay. If you can remember the Kirik Party movie where the opponent from the election is thrown out, okay, before entering the hall, like that. Okay, so preventing the antibiotics from reaching the target. Impaired cell permeability, that means the antibiotics are so prepared that they can pass actually through the semi-permeable cell membrane. Now they become impermeable. Till now they were permeable, but now after acquiring the resistance, it become impermeable. Efflux phenomena is mainly for the streptomycin for tuberculosis. Okay, where they develop efflux mechanism where streptomycin is just thrown out. Then preventing the antibiotics from binding it to the target. That means the target from where for which the HIV antiviral drugs were prepared. Now these targets are changing itself, or the drug is no longer able to bind to the same receptor. Okay, so that's why the resistance are increasing. Supplementary targets or decreased affinity of by target modification and inactivation. Okay, so for example, if you take acyclovir, okay, if you remember, acyclovir is a antiviral drug, okay, which is safe in pregnancy, and it is needed to be converted to its triphosphate or a metabolite which is more active in the antiviral. But nowadays the acyclovir is no longer as effective as it was previously. Okay, have you heard of herpes zoster? They will tell. Okay, we used to prescribe acyclovir 5 times daily, these drugs, but nowadays there is resistance to it because the drug is inactivated or no longer able to act on its target. So genetic exchange among the resistant species, Pseudomonas, Enterobacteria. Okay, cholera everyone has heard. Pseudomonas, they can cause this gram infections, okay, wound infections. Staphylococci, Streptococci, Enterococci, these can cause the pneumonia and other diseases. So these, what on the right side what I am showing is the gram positive ones, okay, on the left side among the gram negative ones. Both rods and cones, these bacilli and cones, they are able to exchange the data regarding the resistance. That is more dangerous for us. So there is a pharmacological concept for or pharmacological angle for this, for new drug development. So there is a term called as MIC. Have you heard anyone? MIC, minimum inhibitory concentration. Okay, so MIC is the concentration which is needed at a particular site or where the bacteria is present, or particular plasma levels which has to be maintained so that the bacteria is killed. Okay, so we have both type of antibiotics, that is the concentration dependent killing or the time dependent killing. Okay, so amoxicillin, the basic what you use, I'll start with that. So amoxicillin, and how long we prescribe? Usually for 5 days. Okay, why? Because amoxicillin is a time dependent killing one. Okay, so that means if the patient completes the course for 5 days, then only the patient will be cured of his disease. Okay, because this is a time dependent killing, and the concentration dependent killing will also be there. So if we understand the concentration dependent killing, that is the fluoroquinolones or the ofloxacin, if you can put a high concentration there, then we will be able to kill. With that concept only, we have so many drugs which are used for shorter duration of time, like azithromycin. You might have heard azithromycin, they used for 3 days only 3 days course. The tablet strip is sold for 3 days. If you are seeing the tablet from long distance also, only 3 tablets are there, we think it is azithromycin strip. Okay, so all these things we have to understand. Why this is important is, this is for the research purpose and also for understanding the antimicrobial susceptibility. There is one more concept called as prescription auditing. So the term itself is self-explanatory. What is this prescription auditing? Why I have stopped here is because the medical shop, if he earns 1000 rupees per day, out of physician, how much you might have heard, you might have earned only 10 or 20 rupees. That means another 980 rupees he has earned without prescription. Over the counter. Everything has become over the counter. Do you agree with me?